Okay guys, so hello guys, my name is Dr. Khan. I am an anesthetist and intensivist. So I'll be dealing with this topic of anesthesia. So guys, let us start with this topic called as spinal and epidural anesthesia, right? Basically, spinal and epidural anesthesia comes under this topic called as central neuraxial block. Central neuraxial block consists of spinal and epidural anesthesia. Apart from spinal epidural, in central neuraxial block, we also have caudal anesthesia and saddle anesthesia. We'll discuss that later. We'll start with what? Spinal anesthesia. Spinal anesthesia. Now guys, first we need to understand spinal anesthesia is used for what surgeries, or what is that spinal anesthesia? I have given you a brief introduction of spinal anesthesia, right? We have discussed about the spinal anesthesia technique previously also. So anyways guys, what is the spinal anesthesia and for what surgeries we use this spinal anesthesia? Spinal anesthesia, is it given on the spinal cord? No, it's not given on the spinal cord. Spinal anesthesia is given below the ending of the spinal cord, right? That's called a spinal. For what surgeries you go for spinal anesthesia? For the surgeries done below the level of umbilicus within 2 to 3 hours of duration, you go for spinal anesthesia, right? So what are the surgeries which are done below the level of umbilicus within 2 to 3 hours? It could be LSCS, it could be appendix surgery, it could be hernia surgery, it could be diabetic foot surgery, it could be any testicular surgery. So any of these surgeries which are done within 2 to 3 hours of duration, you can go for spinal anesthesia. You can go for spinal anesthesia, right? So we know the indication of spinal. You can write there, in the indication of spinal, it is basically spinal anesthesia is indicated for any surgery which is done below the level of umbilicus. Within how many hours? Within 2 to 3 hours of duration. Within 2 to 3 hours of duration. Any surgery done below the level of umbilicus within 2 to 3 hours of duration, you go for spinal anesthesia. That is the indication of spinal anesthesia. Examples of the surgeries such as LSCS is there, hernia surgery is there, right? LSCS is there, hernia is there, testicular surgeries, or any surgery. There are many surgeries. I have just given you 3 examples. It doesn't mean that it is just given for these surgeries. Okay? And many more. Right? So guys, again you have to have an imagination for spinal anesthesia. Imagine you get a call from a hospital saying that there is a lady who's posted for normal vaginal delivery, but the labor is non-progressing. The patient is having non-progressing labor. Means she is having labor pains, but there is no cervical dilatation. And they are telling that we are feeling fetal distress. Due to that, we are now posting the patient for cesarean section. So they are telling you, please give your services for spinal anesthesia or give spinal anesthesia to the patient. So you go to the hospital and now you have to give her spinal anesthesia. So imagine you have done the PAC of the patient, right? And now you have to give her spinal anesthesia. Now guys, once you enter the operation theater, after doing the PAC and all, once you enter the operation theater, if you want to give a spinal anesthesia to this lady, basically this lady will be lying down in supine position on the operation theater table, right? So the first thing before giving spinal is what, guys? What is the first thing that you do before giving spinal? The first thing is the position of the patient. What's the first thing, guys? Position of the patient. The lady which is lying down on the operation theater table, you either make that lady sit or either make the lady lie down. Lie down means what? Lie down in a lateral position, right? Now guys, look over here. There is nothing like which is most commonly done, sitting or lateral. There is nothing but which is most commonly done. But you always have to choose the position accordingly. Okay? You got a call for LSCS. What I usually do, I'll share my experience. If I get a call for LSCS, I go to the hospital. While going into the operation theatre, in the operation theatre, I ask the patient, which position are you comfortable with? Guys, we have to have empathy towards the patient. We need to ask the patient, are you comfortable in sitting posture? Are you comfortable in lateral posture? I have seen many of my patients saying that, doctor, I can't sit. Why? Because the weight of the baby or the weight of the uterus or that uterus is causing much distress. A term uterus will cause much distress to a pregnant lady. So most of the ladies tell me, what, doctor, if it's better, then I'll just lie down in a lateral position. Can you give in that position? I'll tell, yes, I will give. Some of the ladies, when I request them, can you sit and all, they will be happily sitting. They won't have that much of distress. So again, guys, it's not that which is a common position and which is not not the common position. It's basically what? Any position you can choose according to the patient's condition. According to the patient's condition, right? So spinal anesthesia can be given in what position, guys? It can be given in lateral or it can be given in sitting posture. What is the position for spinal? Either lateral or either sitting posture. Either lateral or either sitting posture. After making the position, now what we need to do, position is clear. Now we need to first identify the site where you have to introduce the needle, right? So what site will you choose for giving spinal anesthesia? What site will you choose? Remember, spinal is given for below umbilicus short duration surgery, right? So the site that you choose, basically you have to give the drug in the CSF. In the CSF means you have to insert your needle in the intervertebral space. But what intervertebral space will you choose? Will you choose a cervical? Will you choose a thoracic? Or will you choose a lumbar intervertebral? We will choose a lumbar intervertebral space. Why lumbar intervertebral space? Why? Because we are just blocking the sensations of below umbilicus. We go for a lumbar intervertebral space. Which lumbar intervertebral space? The most commonly chosen spaces are between the L3 to L5. Are between what, guys? L3 to L5. That is the most commonly chosen space, guys. L3 to L5. Why can't I go for an L1 space or why can't I go for L2 space? We usually don't insert the needle at the L1, L2. Why? Because there is a risk to damage the spinal cord. As the spinal cord in adults, you can see over here, as the spinal cord in adults, it is ending at the lower border of L1 and upper border of L2. Whereas in children, the spinal cord ends at L3 level. Okay? So the spinal cord in adults, it is ending at between the lower border of L1 and upper border of L2. That's why we avoid one or two spaces. Okay? We choose the L3, L5 space. We choose the space called as L3 to L5. But how will you come to know this space is L3, L5 space? Will you count all the vertebrae from top till L5? No. What we need to do, guys, there is a landmark or there is a line that indicates that you are in the L3 to L5 space, or most commonly is L4, L5 space. What is that line? What is that line? You basically stand behind the patient. Okay? You are standing behind the you stand behind the patient. To locate that line, you have to stand behind the patient. Keep your two hands and take your two hands and keep your two hands on the highest point of the iliac crest. Keep your two hands like this on the highest point of the iliac crest. Thumb like this. Okay? An imaginary line can be drawn between your thumb that line is called as Taffier's line, which indicates L4, L5 space, which indicates the L4, L5 space. So once again guys, what are we discussing? We are discussing about the how to locate the site in spinal anesthesia. We stand behind the patient, we take both the hands, we keep both the hands on the highest point of the iliac crest and thumbs like this. An imaginary line can be drawn between your thumbs. That imaginary line indicates the Taffier's line. That is called as Taffier's line, which indicates the L4, L5 space. In some patients, it indicates the L3, L4. So it will be easy to identify the space with the help of Taffier's line. With the help of Taffier's line. What is Taffier's line? We have already discussed. By keeping both the hands on the highest point of the iliac crest, you can locate the Taffier's line. That was regarding what? That was regarding the site. So once again guys, for spinal anesthesia, the first thing that we need to look is what? Indication we have already discussed. For below umbilicus, short duration surgeries. Next thing is what guys? Position of the patient. Lateral or sitting. After position is the site of the patient. What site will you choose? It is basically either a L3 to L5 space. Most commonly chosen site is what guys? L3 to L5 space. And how will you identify that's L3 to L5 space? Just right there. Keep both hands on highest point of iliac crest. Keep both hands on the highest point of the iliac crest. An imaginary line can be drawn between the thumbs. An imaginary line can be drawn between the thumbs, which indicate what line guys? Which indicate that imaginary line indicates what? That imaginary line is Taffier's line. That is called as Taffier's line. That indicates the L4, L5 and in some patients L3, L4 space. In some patient it indicates the L3, L4 space. So we know the site. Okay? After site, now will you directly insert the needle once you know the site? We don't insert the needle. First we clean the site. We know the position, we know the site, then we need to clean the site. How will you clean the site in spinal anesthesia? How will you clean the site in spinal anesthesia? For cleaning the site, first we apply a red color solution which is called as betadine or iodine solution. After applying that red color solution, what we do? We apply a surgical spirit to remove the solution. Why, sir? Why are you first applying betadine and why are you then removing that betadine? Remember guys, betadine is a mandatory thing that needs to be applied for sterilization. It gives a better sterilization than surgical spirit. Remember, why are you first applying and then why are you removing it? Remember guys, if you just apply betadine and insert your spinal needle over the betadine, what will happen? Your spinal needle takes that betadine, leaks that betadine into the CSF, leading to chemical meningitis caused by the iodine solution. That's why what we do, first we apply betadine, next we apply surgical spirit to remove the betadine, next we apply the dry cotton. Now the area is totally ready for the introduction of your spinal needle. Spinal needle, okay? So, how will you clean the site guys? For cleaning the site, what we need to do? For cleaning the site, first we need to apply betadine. After application of betadine, we need to apply surgical spirit. After application of surgical spirit, we need to apply dry cotton. Now the area is totally ready. Now the area is totally ready to receive the spinal needle. right? So the next step, the fourth step in spinal anesthesia is the needle. Needle. No one will ask you the chronological order of the steps and all. Just for your remembrance, I am telling, okay? Needle. Needle, guys. While giving spinal anesthesia, my question to you is, will you use a dura cutting needle or will you use a dura separating needle? Needle, I'll write it over here, guys. You can take it down from here. Needle that we use in spinal anesthesia. My question to you is, will you use a dura cutting needle or will you use a dura separating needle for spinal anesthesia? That is my question. So most of you, I can make it out that most of you don't know the answer. Why? Because we basically don't know what is dura cutting and what is dura separating. If you want to understand what needle should be used, first we need to understand what are the layers pierced by your needle. Then we'll come back to this question, what is the needle that is being used in spinal anesthesia? So look over here, guys. We are talking about the needle. So I'm not going to the question which needle is used. As you are passing the needle through the skin, what are the layers pierced by your needle? First we need to understand this, then we need to understand which needle is used. Okay, so the structures that are pierced as you are passing the needle through the L4 L5 space, as you are inserting the needle through the L4 L5 space, right, the structures that are pierced in spinal anesthesia, the first structure is what, guys? The first structure over here is what? It is skin. After skin, what is the next structure? Subcutaneous tissue. Subcutaneous tissue. Next, what is the structure? Supraspinous ligament. Supraspinous ligament. Next, what is the structure? Interspinous ligament. Next, what is the structure? Ligamentum flavum. Ligamentum flavum. Now here we need to stop for a while. First we need to understand what is this ligamentum flavum. It doesn't mean that it is the last layer. Just look over here. What is the importance of ligamentum flavum? Ligamentum flavum is thought to be the hardest or the toughest ligament in spinal anesthesia. Ligamentum flavum is regarded as what, guys? It is regarded as the hardest or toughest ligament in spinal anesthesia. Once your needle pierces the ligamentum flavum, you will come to know that I have pierced ligamentum flavum. Just guys, look over here. First we will revise this. Just look over here. As you are passing your needle, imagine your needle is passing through the structures. The first structure is called as skin. Next, subcutaneous tissue. Next, supraspinous ligament. Next, interspinous ligament. Next, ligamentum flavum. Ligamentum flavum. As I am passing ligamentum flavum, you can see the needle direction is suddenly changed, or needle direction, no, the needle movement which was going smoothly, suddenly it goes in. Why? Why? Because your needle has now just pierced the ligamentum flavum, which was the toughest. Once you pierce anything that is tough, you will feel a sudden loss of resistance. So how is ligamentum flavum pierced appreciated? The ligamentum flavum piercing is appreciated by sudden loss of resistance or a snap. Sudden loss of resistance or snap, right? Ligamentum flavum is pierced, you will feel a sudden loss of resistance or a snap. Once ligamentum flavum is pierced, the next layer to be pierced in spinal anesthesia is what, guys? It is the dura. It is the dura. Once you puncture the dura, you will be in the arachnoid, right? You have to puncture the arachnoid. So the last layer to be pierced in spinal anesthesia. The last layer to be pierced in spinal anesthesia is what? Arachnoid. Once you puncture the arachnoid, you will be in a space called as subarachnoid space that has what? This subarachnoid space has the C of CSF. What does the subarachnoid space have? This subarachnoid space have the CSF. This is the subarachnoid space that has the CSF. So once again guys, as you are passing your needle through the skin to the subarachnoid space, what are the layers that are pierced? First is the skin, next subcutaneous tissue, next supraspinous ligament, interspinous ligament, ligamentum flavum. Once you puncture ligamentum flavum, you will feel what? A sudden giveaway feeling or sudden loss of resistance or a snap. Next after ligamentum flavum, dura. Next after dura, it is the arachnoid. The last layer to be pierced in spinal anesthesia is what guys? Arachnoid. Okay? The order of the layers is very important. Last layer to be pierced in spinal is very important. And ligamentum flavum is also very important. There have been questions on which is the toughest layer in spinal. Answer is ligamentum flavum. One more question was on piercing of ligamentum flavum, what is felt? Answer is sudden loss of resistance or a snap is felt. So guys, coming back to our question, what needle will we use for spinal anesthesia? Now guys, just look over here. Whenever you are choosing a needle for spinal anesthesia, your main concern should be, I should not damage the dura much. I should not damage the dura much. If my needle damages the dura much, what will happen? If your needle damages the dura much, what will happen? There will be a hole inside the dura. Due to the hole inside the dura, the CSF gets leaked out and the patient will develop headache. So guys, my question to you was, what needle are we using for spinal anesthesia? So everyone just look over here with a good concentration. Imagine this thing which I am drawing is dura. This is dura. Just beneath the dura you are having arachnoid, and then you are having the subarachnoid space. And I told you guys, in the subarachnoid space, what do we have? In the subarachnoid space, we have the CSF, right? So this is the picture of the dura after using a dura cutting needle. After using a dura cutting needle. In the next thing, just look over here. Again, this is the dura, right? Beneath the dura is the arachnoid, and beneath the arachnoid is what guys? Subarachnoid space. Again guys, in subarachnoid space, what do you have? CSF, right? So the question was what needle are we using? In this patient, I have used dura cutting needle. In this patient, I have used dura separating needle. If I use dura cutting needle, just look at the damage of the dura guys. How's the damaged part of the dura? It's very much. If the damaged part of the dura is very much, what will happen? What will happen guys? Due to the damaged part of the dura, from this damaged part, what happens? The CSF gets leaked out, leading to what? Leading to headache. Such a headache that is occurring due to the damage of the dura is called as post-dural puncture headache. It is happening due to the puncture inside the dura. Hence it is called as what guys? Post-dural puncture headache, right? So if you are using dura cutting needle, there are many chances of PDPH. There are many chances of PDPH. What is PDPH? Post-dural puncture headache. If you are using dura cutting needle, there are many chances of post-dural puncture headache. But if you are using dura separating needle, just look over here guys. How's the damage to the dura? It is very less. If the damage to the dura is less, it will heal easily also, and there will be no leak of CSF. Hence, the chances of patient developing PDPH are very less. So guys, if you use dura separating needle, there will be less chances of PDPH. So the choice is in front of you. The question remains same. What needle will you use now? Everyone will get this concept clear. The needle that we use in spinal anesthesia, it's what needle, guys? What's the needle that we use in spinal anesthesia? It is the dura separating needle. It is a thin bore dura separating needle, right? This dura separating needle is also called as Sprotty's or Whittaker's needle. Sprotty's or Whittaker needle, right? Whereas dura cutting needle is called as Quincke's needle. Dura cutting is called as what needle, guys? Quincke's needle. So which needle will you use for spinal anesthesia? I think it gets clear to you. The needle that we are using for spinal anesthesia is a dura separating. It is a thin bore dura separating needle. If you use a thick bore needle, what will happen? Much damage to the dura, and again PDPH chances are there. So guys, once again, the needle that we use in spinal anesthesia is a thin bore dura separating needle. The dura cutting needle is not used. Dura cutting needle is not used. Okay, this was regarding what? This was regarding the needle. So guys, in spinal anesthesia, we know the indication of spinal, below umbilicus, short duration. We know the position of the patient. What's the position of the patient, guys? Sitting or lateral. We also know what? After the position, we also know about what, guys? The site. How will you choose the site? How will you clean the site? And what needle should be introduced? So guys, next, once you are in the subarachnoid space, how will you confirm that you are in the subarachnoid space? Imagine your needle is in the subarachnoid space. In the C of CSF, your needle is there. Here the needle has been planted. How will you come to know that you are in the subarachnoid space? Once you are in the subarachnoid space, remove the guide wire from the needle. Wait for the drops of CSF. There will be a thin guide wire inside the needle. Once you are in the subarachnoid space, remove the guide wire. Keep the needle inside the space only. And you wait for the drops of CSF. Once you see the drops of CSF coming, what we need to do now? Now we need to inject the local anesthetic. But remember guys, which is the most commonly used local anesthetic in spinal anesthesia? Bupivacaine. Bupivacaine is the most commonly used local anesthetic in what anesthesia? Spinal anesthesia. So guys, can you give bupivacaine? And you guys also know that bupivacaine is the most cardiotoxic local anesthetic, right? So before giving that bupivacaine, take this bupivacaine syringe, attach to the spinal needle, and before injecting the drug, first aspirate some CSF. First aspirate some amount of CSF back into your bupivacaine syringe. Why are you aspirating that CSF? Why? Because you need to make sure that the bupivacaine that you're giving to the patient, it goes in the CSF, not in the blood. If you see any red color or if you see some blood coming with CSF, stop over there. Don't give that bupivacaine. Why? Because we already know bupivacaine is what, guys? It is the most cardiotoxic local anesthetic. It's the most cardiotoxic local anesthetic. So once you are in the subarachnoid space, once we are in the subarachnoid space, we remove the guide wire from the needle. We remove the guide wire from needle. Needle means spinal needle. And wait for the drops of CSF. Wait for the drops of CSF. So, once you wait for the drops of the CSF, once you see the drops of the CSF, you directly don't give this bupivacaine. What we do, guys? We aspirate some 0.5 to 1 ml of bupivacaine into the syringe, which is called as, this aspiration of bupivacaine back into the syringe is called as barbotage. It's called as barbotage. So once you are in the CSF, we aspirate some 0.5 to 1 ml of bupivacaine, and then we inject this bupivacaine. Okay, that aspiration of CSF back into the syringe is called as barbotage. Then we inject this bupivacaine. Right? So this was the procedure of spinal anesthesia, guys. This was the procedure of spinal anesthesia. Now what we need to discuss is basically the complications of spinal anesthesia and how will you manage the spinal anesthesia complications. Okay, but before going to the management of the complications, or before going to the complications, come on guys, I have already told you one thing. A good doctor is one who sees the complication and then manages it, or a good doctor is one who anticipates the complication beforehand and then manages it. Who is a good doctor? A good doctor is one who anticipates the complication beforehand and then manages it. So we have to be a good doctor, guys, especially for anesthesia. I'm telling you, okay, you have to be a good doctor in every field, but still, just look over here. What are we doing over here? We are anticipating the complications associated with spinal anesthesia. What complications are you anticipating? Before going towards the anticipation, first we will fill in that what the rule that I follow, guys. I don't know about other anesthetists. The rule that I follow before giving spinal anesthesia, I prepare an emergency drug tray. I prepare an emergency drug tray. In the emergency drug tray, I keep some drugs. What are the drugs that I keep in the emergency drug tray? I keep a drug called as phenylephrine. I keep a drug called as phenylephrine. I keep the second drug in the emergency drug tray as atropine. Second drug that I keep is atropine. The third drug that I keep in the emergency drug tray is what, guys? I have kept phenylephrine. I have kept atropine. I will keep pethidine. I'll keep pethidine. And the last column of the emergency, it's basically the continuation of the same tray, guys. It doesn't mean that that tray is different, this is different. It is a continuation of the same tray. In the last column of the emergency drug tray, I keep a laryngoscope, ET tube, and adrenaline. I keep laryngoscope, ET tube, and adrenaline. Right? So in the emergency drug tray, I have kept phenylephrine, I have kept atropine, I have kept pethidine. We have to remember in this order only. And the last thing that I have kept is laryngoscope, ET tube, and adrenaline. I know some of you might be thinking that this guy is talking about spinal anesthesia, but in spinal anesthesia, what is the use of laryngoscope, ET tube? Okay? We'll come to it, guys. We'll come to it. Okay? So before giving spinal anesthesia, the first drug that you have kept is what, guys? Phenylephrine. Why have you kept this drug ready as phenylephrine? Why have you kept this drug ready as phenylephrine? Why? Because we have anticipated the complication. The most common complication of spinal anesthesia we have anticipated. What is the most common complication of spinal anesthesia? The most common complication of spinal anesthesia is hypotension. Hypotension is the most common complication of spinal anesthesia. Why do you see hypotension, guys? What is the reason for patient developing hypotension in spinal anesthesia? I'll tell you what's the reason behind it. Why the patient develops hypotension in spinal anesthesia. Guys, everyone look over here. You will come to know what's the reason for patient developing hypotension. So imagine I have given spinal anesthesia to this patient. If I give spinal anesthesia to the patient, what will happen, guys? The sympathetic activity of the lower part of the body, the sympathetic activity of the lower part of the body will be gone, right? The sympathetic activity of the lower part of the body will be gone. If the sympathetic activity of the lower part of the body is gone, what will happen to the blood vessels? Remember, guys, first of all, the sympathetic activity is responsible for So guys, as I already told you, as we give spinal anesthesia, what activity is gone? The sympathetic activity of the lower part is gone. Sympathetic system is responsible for vasoconstriction, right? As we give spinal anesthesia, we block the sympathetic activity, and as sympathetic activity is blocked, what will happen to the blood vessels? The blood vessels will dilate. Where the blood vessels will dilate? Where the spinal is working. In the lower part. So as we give spinal anesthesia, what happens? It causes sympathetic blockade that leads to vasodilation, dilatation of the blood vessels in the lower extremities, As you see dilated blood vessels in the lower extremities, what do you see, guys? As you see blood vessels are getting dilated in the lower extremities, what will happen? All the blood volume from the upper part of the body, it will go down and it will settle at the bottom. Where is the blood volume going, guys? All the blood volume is going down and settling at the down. If all the blood volume gets settled at the lower part of the body, what will happen to the blood volume in the upper part? The blood volume in the upper part will be decreased. What happens to the venous return of the heart? The venous return decreases. What happens to the cardiac output? The cardiac output decreases. Then what happens to the BP? The BP also decreases. Hence, the most common complication of spinal anesthesia is what, guys? It is hypotension. The most common complication of spinal anesthesia is what, guys? It is hypotension, right? Why is hypotension regarded as the most common complication? You know the reason. Hypotension produces sympathetic blockade that causes vasodilation of the upper part of the body. The vasodilation of the lower part of the body. All the blood from the upper part gets settled down at the bottom, right? The blood volume in the upper part is reduced, the venous return is decreased, the cardiac output is decreased, hence the patient is having hypotension. But we are having the drug to manage that hypotension. The drug of choice for hypotension in spinal is what? It is phenylephrine. It is what, guys? Phenylephrine, right? The treatment of choice for hypotension in spinal is what, guys? It is phenylephrine. In the emergency drug tray, the first drug which I kept was phenylephrine. Why did I keep this drug ready? Why? Because the most common complication of spinal anesthesia is hypotension. To manage that hypotension, we have kept this drug called as phenylephrine. So you give phenylephrine to the patient BP will increase. Phenylephrine will increase the patient's blood pressure, right? Now, as you are giving this phenylephrine, you will notice some change in the heart rate of the patient. What happens to the heart rate of the patient while you have given, imagine, basically in not all patients, but in some of the patients, you have given phenylephrine, the patient's BP increases. So imagine you have given phenylephrine, now you see there is good blood pressure, you are happy, but slowly what you see is the patient's heart rate, which was 72, it has become 60. It's not a problem for me, it's not a problem for you also. Now it becomes 50. 50 heart rate means now the heart rate has slowed down, right? The patient has landed up into a condition called as bradycardia. But why did this patient land up into bradycardia? If at all your drug blocks the cardioaccelerator fibers, the patient will develop bradycardia, right? But even though heart rate is 50 or it becomes 50 or it becomes 48, I am not in any worries. I am not in any tension. You guys should also not take any tension. Why? Because beforehand we have prepared the emergency drug tray. In that, the second drug that we have kept is what, guys? Atropine. Atropine. Why did we keep this atropine ready? Why? Because the second complication, the second most common complication of spinal anesthesia is what, guys? Bradycardia. And the management of bradycardia, for the management of bradycardia, hum kya denge? What we will give? We'll give atropine. So you have given phenylephrine for hypotension, you have given atropine for bradycardia. So now you are totally happy that the patient is not having any other complication, but whenever you are happy, the patient will show a complication. Okay? We are discussing about the intraoperative complication, guys. Intraoperative complication, the most common intraop complication of spinal is hypotension. Next complication, bradycardia. So now you are happy, the patient is not having any problem. Now slowly a patient will have what? Patient will have shivering. Shivering. Why did this patient have shivering? Why did this patient have shivering? Why? Because the same reason why he had hypotension. If you guys remember why he had hypotension, guys, why did a patient develop hypotension? Because the blood vessels in the lower extremities were dilated. All the blood was settling down at the bottom. Blood is one of the important things that maintains our temperature. If all my blood is going and settling down at the bottom and telling the upper part of the body I won't be coming over there for some time, what will happen to the upper part of the body? Due to loss of blood, all the blood is going at the bottom, upper part of the body, patient will have shivering. But again, guys, you and I both don't have to worry about this complication called as shivering. Why? Because what are we having? We are having the emergency drug tray. In the emergency drug tray, the third drug that we have kept is pethidine. Pethidine. Why did you keep pethidine? Pethidine is an opioid or is a drug of choice for management of shivering in spinal. Management of shivering in spinal anesthesia. Right? That's regarding what, guys? That's regarding pethidine. Next complication that you see in spinal anesthesia is, now we have discussed some of the complications, guys. We have discussed some of the complications. Right? We have discussed the most common complication. Second most common is bradycardia. For that you give atropine. Third complication is shivering. The next complication that you see in spinal anesthesia or that you see after spinal anesthesia is what, guys? Is high spinal and total spinal. These are the next two complications. High spinal and total spinal anesthesia. What is meant by high spinal anesthesia and what is meant by total spinal anesthesia? High spinal or total spinal anesthesia. So when do you call it as high spinal and when do you call it as total spinal? First we need to be clear, guys. Okay? First, before going to high spinal and total spinal, what we need to know is, we need to know some dermatome values. We need to know some dermatome values. Okay? Dermatome values corresponding to what? You might be knowing, guys, or some of you might not be knowing what are the dermatome values. Just look over here. Imagine this is the human body, right? Just look over here, guys. Right. Over here, we are discussing about the dermatome values. Nipples correspond to what dermatome value? Nipples corresponds to T4. Xiphoid sternum corresponds to T6. The area between xiphoid sternum and umbilicus corresponds to T8. Umbilicus corresponds to T10. Umbilicus corresponds to T10. T6 is xiphoid sternum. T4 is nipples. T8 is the area between xiphoid sternum and umbilicus. T12 is pubic symphysis. T12 is pubic symphysis. Right? So what are we talking, guys? Why are we talking about this dermatome? So imagine a patient is posted for hernia surgery. When a patient is posted for hernia surgery, imagine you want the level of your drug to block till T6. Till T6 you want the block. Okay? You have given spinal to the patient, you make the patient lie down. Now, how will you come to know after making the patient lie down, how will you come to know that your drug is acting till T10 or T12 or T6? How? By asking the patient. Asking the patient, or by what? By you take a needle and you scratch the needle near the pubic symphysis. Ask the patient, are you having pain? Patient is telling that, doctor, I don't have any pain. If he is not having pain, that means T12 is blocked. Then take your needle and scratch it near umbilicus. Ask the patient, are you having pain? Patient is telling, doctor, I don't have pain. That means T10 is blocked. Take the needle and scratch near the umbilicus and xiphoid sternum. Ask the patient, are you having pain? He'll be telling, doctor, I don't have pain. That means T8 is blocked. T8 is blocked. And scratch the needle near the xiphoid sternum. Ask the patient, are you having pain? That means T6 is blocked if he's not having pain. So imagine a scenario, guys. You have given spinal. You make the patient lie down. Okay? The one scenario which I told you, it was for a normal case. Now, for this case, we have given spinal. We took the needle. We scratched near pubic symphysis. Patient is telling that, doctor, I don't have pain. Yani ki T12 is blocked. But what is your level that you want? T6 you want. You want your drug to act till T6 or xiphoid sternum. You scratch it near pubic symphysis. Patient is telling no pain. That means T12 is blocked. You take the needle and scratch near the umbilicus. Now the patient is telling, doctor, I am able to feel the pain. Please stop. Don't do that. Now what will you do? You want your drug to act till T6, but your drug is still just acting at T12. Now what will you do? What will you do? Will you tell the drug to go up and block T6, or will you make the drug go up? You will make the drug go up. How will you make the drug go up? The patient is lying down in a supine position, no? So after giving spinal anesthesia, make the patient lie down in a head-low posture. Make the patient lie down in what posture? Head-low posture. As you make the patient lie down in a head-low posture, what will happen? The drug you have given in the CSF, that drug, slowly from T12 it will block T10, from T10 it will block T8. But it's a very risky thing, guys. To make the patient in head-low posture, it's a very risky thing after spinal. Why risky? Why? Because the drug can ascend into the intracranial segment also if you have not taken care. So what I do is, if at all the drug is acting till T12 only, I make the patient lie down in head-low posture. I take the needle and after 1 minute, I scratch it near the umbilicus. I ask the patient, are you having pain? Patient will tell, doctor, no pain. That means T10 is blocked. I take the needle, scratch near the umbilicus and xiphoid sternum area. Ask the patient, are you having pain? Patient is telling no pain. That means T8 is blocked. Take the needle and scratch near the xiphoid sternum. Ask the patient, are you having pain? Patient is telling no pain. I'll be very happy that I have achieved a T6 block. Now immediately what should I do? I should make the patient lie down in what posture? In a normal supine posture. In a normal supine posture. Right? So remember, guys, Trendelenburg position is done in order to move the drug a bit up. But guys, with very much care. Right? Why? Because if the drug goes a bit up, then it can cause a complication called as high spinal. Now guys, coming to what is high spinal anesthesia. High spinal means you have given spinal anesthesia, you made the patient lie down. You wanted, your desired level was T6. Your desired level was T6. Now you take your needle, scratch near pubic symphysis, ask the patient, pain is there kya? Patient is telling no pain, sir. Take the needle, scratch near the umbilicus. Patient is telling pain is there. You make the patient lie down in head-low posture. Okay? Now, take the needle and scratch near umbilicus. No pain, T10 is blocked. Take the needle, scratch between the umbilicus and xiphoid sternum. No pain, T8 is blocked. Take the needle and scratch near the xiphoid sternum. No pain, T6 is blocked. Okay? Make the patient lie down in a normal posture. But after making the patient lie down in a normal posture, you are having one small doubt in your mind whether the drug has gone a bit up kya. You're thinking about the drug has gone a bit up kya. How will you confirm? You take the needle and scratch near the nipples. Now the patient is complaining of pain. You take the needle and scratch near the nipples, and now the patient will tell, doctor, I don't have pain over here also. Now what will happen, guys? Basically, you wanted T6 to be blocked, but as there is no sensations at T4, T4 is also blocked. So what is that complication called as? Just look over here. What was your desired level? Your desired level was T6, but what have you achieved? You have achieved a higher level of T4. When your achieved level is higher than the desired level, that complication is called as high spinal anesthesia. That complication is called as what anesthesia, guys? High spinal anesthesia. What is high spinal? I am writing from here. When the high spinal anesthesia is what? When the achieved level of block, when the achieved level of block is higher than the desired level, higher than the desired level, it is called as high spinal anesthesia. That thing is called as high spinal anesthesia. In high spinal anesthesia, what do you see? High spinal anesthesia is characterized by two things together. Very, very important. In high spinal, you see hypotension and bradycardia together. The first two complications of spinal you will see together. Hypo and brady together. In high spinal, you will see hypotension and bradycardia together. Now, guys, are you worried? Are you worried about this high spinal? Answer should be no, sir, I am not worried. We are not worried. Why we are not worried? Why? Because we have an emergency drug tray in which we have the drugs to manage this hypo and brady. What is the drugs given over here? If the patient develops hypotension, go for the first drug of the emergency drug tray, phenylephrine. If the patient has bradycardia, go for the second drug. What is the second drug in the emergency drug tray? Atropine. So that's regarding high spinal. Then there is one more complication called as total spinal anesthesia. We are discussing still about the complications of anesthesia. The most common complication of spinal anesthesia is hypotension. The second complication is bradycardia. The next complication is shivering. Okay? Next complication is high spinal. Next intra-op complication is total spinal. What is total spinal? Imagine, guys, actually this has happened with me. What I did is, I gave spinal anesthesia. I was in my first year. I gave spinal anesthesia, first year anesthesia PG. I gave spinal anesthesia to the patient. Then I make the patient lie down. I took the needle. I go for a prick, scratch test. I scratched it near pubic symphysis. Asked the patient, are you having pain? Patient was telling, no pain, doctor. Then took the needle and scratched it near umbilicus. Asked the patient, are you having pain? Patient was telling, pain is there, doctor. So what I did? I made the patient lie down in what posture, guys? I made the patient in a head-low posture. Head-low or Trendelenburg posture. Okay? Ideally, what should be done after making the patient in head-low posture? You have to check the level. Okay? But what happened? Immediately after making the patient in head-low posture, my head of the department came into the operation theatre, and my head of the department was an angry man. He came to the operation theatre saying that, Dr. Khan, I gave you some work. Is the work done or not? So after seeing him, I got panicked and basically I told, no sir, I have to do it. So he screamed at me, he yelled at me, and he told me, just go and do that work and tell someone to come cover up your case. So what I did is, I went to do the work. The work was done within like 5 minutes, right? I told some other anesthetist to cover my OT. Then I came back to my operation theatre. When I came back to my operation theatre, I saw the patient in a head-low posture. I forgot why the patient is kept in a head-low posture. But in the next moment, I realized I only made the patient in a head-low posture. What I did, first I make the patient in a normal posture, and now I took the needle, scratched near the umbilicus, asked the patient, are you having pain? Patient was having no pain, that is T10 is blocked. Then scratched it near the area between umbilicus and xiphoid sternum. Patient was telling no pain, that means T8 is blocked. Took the needle and scratched it near the xiphoid sternum. Asked the patient, are you having pain? Patient was telling no pain, that means T6 is blocked. I was happy, but at the same time, I was very much tensed. Why? Because I have kept the patient in a head-low posture for longer time. What will happen? I have given the drug in the CSF. Through the gravity, the drug will go up, yes or no? I took the needle and scratched it near the nipples. T4 was blocked, no pain. I took the needle and scratched near the neck of the patient, hopelessly thinking, basically I was praying in my mind and in my heart that patient should have pain at least over there. Patient was having no pain. While she was answering, patient was having this kind of breathing. She was having difficulty in breathing, right? When I scratched near the neck region, I asked the patient, are you having pain? She was telling, no pain, doctor. I got very much panicked. Why? Because spinal should act only at the lower part. I made the patient in a head-low posture. I made the drug travel up. Now the drug has moved through the CSF. The drug has moved into the intracranial segments. The patient was having respiratory difficulty. The patient was having brady with respiratory difficulty. I got very much panicked, but one of my seniors was there. As I was junior, I was not able to know what is that happening and all. One of my senior, he came to the operation theatre. He told me not to be panicked over here. Why? Because I had this habit of, my senior only taught me, guys, to prepare an emergency drug tray. So I had this habit of preparing emergency drug tray. He told me, don't panic and all. I told, sir, this patient is having difficulty in breathing. The patient's saturation is falling. Patient is having hypo. Like in total, first of all, guys, get this concept clear. What is total spinal? Total spinal anesthesia means movement of the drug into the intracranial segment is total spinal anesthesia, which is characterized by brady, respiratory discomfort. If you don't manage respiratory discomfort, patient will ultimately land up into an arrest called as what arrest? Respiratory arrest that can lead to what arrest? Cardiac arrest, right? So my senior, he told me, Dr. Khan, don't panic. Why? Because he showed me, you're having emergency drug tray, no? So why are you panicking? I told, sir, the patient is having hypobradyarrest. Use the first and second drug in the emergency drug tray for hypo and brady management. What is the first and second drug? Phenylephrine and atropine, hypo and brady. And then I told, sir, patient is having respiratory discomfort. He told, what will you use in emergency drug tray? What is kept for patient having respiratory discomfort? If the patient is having respiratory discomfort, you give the patient oxygen, either by mask or the best way is what, guys, you intubate. So that's why in the emergency drug tray, last column, what we have kept, a laryngoscope and ET tube. So what I did, I took the laryngoscope, I intubated the patient, I kept the patient on ventilator, right? I kept the patient on ventilator. Then after 2 hours, remember the drug that we gave was bupivacaine. Our bupivacaine acts for 2 to 3 hours only. After 2 to 3 hours, once the effect of bupivacaine was gone, then what I did, I extubated the patient, right? So everything was there in front of me. I got panicked. Why? Because I was not knowing the complications beforehand, right? I just prepared the emergency drug tray. Why? Because my senior told me. I did not ask why are we preparing and all. Right, guys? Develop this habit of questioning, guys. Questioning is very, very, very important. Not only in this, every field you have to question. Okay. So anyways, guys, over here, what we are doing, what I did, if a patient developed total spinal anesthesia, what do you need to do? First, you need to give phenylephrine as in total spinal. What do you see, guys? First, right there, guys, what is total spinal anesthesia? Total spinal anesthesia is movement of drug into the intracranial segment. Movement of the drug into the cranial segment is called as total spinal anesthesia, right? So movement of drug into the intracranial segment is called as total spinal anesthesia. Total spinal anesthesia. Total spinal anesthesia is characterized by what? Total spinal anesthesia is characterized by hypotension, bradycardia, respiratory discomfort. If you don't manage this respiratory discomfort, you guys know what happens. Respiratory arrest can happen, leading to what arrest? Cardiac arrest. But if you are having emergency drug tray, you don't have to panic. You can easily manage that by intubating the patient. If at all, during intubation or after intubation, the patient develops cardiac arrest, rare of the rare. If patient develops cardiac arrest, no need to panic. Start your CPR and give the drug of choice for cardiac arrest, which is still there in your emergency drug tray. What is that drug? Adrenaline. Right? So laryngoscope, ET tube and adrenaline are usually given to manage what anesthesia complication? Total spinal anesthesia. Total spinal anesthesia.